Great. Well, thank you all for joining us. I'm Debbie Deiner. I decided to be a little bit more informal. It's the afternoon, so if you can't hear me, I will stand there, but I've never been accused of having too soft a voice. Before we get started, before I introduce this terrific panel and our topic, I handed out, and I know, Kat, you also did, one of the topics that Adrian is going to be discussing, and that's embedded in all of our discussions, is the Patient Privacy Rights Trust Framework. If you didn't get a copy, raise your hand. We can get a copy to you. So let me see. 2 up there. Well, I'm going to step off the stage and get you copies, and I'll be right back.
Oh, here. Can you be all
okay. Thank you. Okay, they're also on the thumb drive. So what we're going to be discussing today is a broad topic, but a fascinating one, especially given what we've been hearing all morning. And let me tell you how we'd like to proceed. I've been talking with my panelists over the last 2 weeks or so. They are going to cover, from their unique perspectives, aspects of our broad topic: patient data in the cloud, how is it used, how is it protected. We heard a lot of very interesting information this morning. Doc Searles talking about your personal cloud, talking about just recently in this last panel, the whole new constitutional environment for personal and data, so the cloud becomes even more important. What we're going to do, and I'll introduce everyone, is you've got their longer bios in the program, so as esteemed as they are, we're not going to take time to go over that right again. You're more than welcome to read it and see how impressive each of our panelists is. And I'll exclude myself from that. But what we're going to do is take 5 minutes each. They'll give you their opening comments, and then what we'd like to do is hold questions till the end, so that way you'll have the full understanding of what each of them wants to cover in their high points, and then we'll open it up for questions. And what the handout I just gave you is when Adrian Gropper, he'll be talking, and he'll make a reference to Appendix A. So again, thank you all. I want to thank Debra Peel and her staff for having this terrific conference. I'm Debbie Deiner. I've been a federal employee, now retired, but I served in the federal government for over 30 years, doing privacy, criminal law prosecutions, congressional work, and I'm now an independent consultant. We're going to go in the order of the presentations this morning. So to my immediate right is Maneesha Mithal. She is the Associate Director of the Division of Privacy and Identity Protection, Federal Trade Commission. To Maneesha's right is Kim Little, who is the Director of Market Planning, Identity Management Solutions for LexisNexis, and to her right is Dr. Adrian Gropper. Adrian is a non-practicing physician, but he's also the Chief Technology Officer for this organization, for the Patient Privacy Rights Organization. And to his right is John McDaniel, who is the National Practice Leader, Provider Market for NetApp. So again, we've heard so many interesting comments touching on and beginning to look at the cloud. So we will plunge right in, and I will turn to Maneesha.
Thanks very much, Debbie. It's a pleasure to be here today. And I thought what I would do in my opening remarks is just give a very brief overview of the FTC's role in health privacy. I'll first talk about the laws that apply, second about our policy efforts, and third, I'll touch upon enforcement. So just kind of some perspective here. There's a lot of health data, as Debbie alluded to, that is not maintained by covered entities under HIPAA, so not maintained by doctors' offices or hospitals or insurance companies, but there are ad networks that are tracking you online and can collect health data. There are data brokers that can get information about your purchases at various stores. So there's lots of ways that they're kind of direct to consumer, the Fitbit, the physical fitness devices that you connect to your mobile app. So there's a lot of kind of direct to consumer, behind the scenes entities that are collecting health data that are not covered by HIPAA. So the good news is this is not a complete Wild West. There is a law that applies to these companies that are collecting data in most sectors of the economy, and that's the Federal Trade Commission Act. And the law prohibits deceptive and unfair practices. So deception is fairly easy. If you lie about, you say, I don't share your information with third parties, and you do, that's a deceptive practice. Unfairness is a little more complicated, but it basically boils down to the fact that if you collect data or use data in a manner that causes or is likely to cause substantial consumer injury, and that injury is not outweighed by benefits to competition, then that can be considered an unfair practice. And one of the main areas in which we've used our unfairness authority is in the data security area. So companies that don't maintain reasonable security for sensitive personal information they collect, we've alleged that they violated the FTC Act, and we have sued those companies. We've settled all of our cases except for one. So with that brief intro, let me move on to what we've done on the policy front. So we have these laws that prohibit deception and unfairness, but we also put out a report last year on best practices in the area of privacy. And these best practices apply equally to the area of health privacy. And so our report laid out 3 best practices. First, we encouraged companies to implement privacy by design. And so what that means is don't collect information unless you need it, maintain reasonable security for the data that you do have, and dispose of data when you no longer have a business need for it. We also talked about privacy by design as a process. If you're collecting sensitive consumer information, make sure that you have somebody who's thinking about privacy issues. For a small company, it doesn't have to be somebody with a lofty title like Chief Privacy Officer. It's just you have to designate somebody to think about privacy. You have to make sure that you're baking in privacy before you're unveiling products and services, employee training, having written policies and procedures. These are all best practices on privacy by design. The second thing that we called for was the idea of just-in-time choices. You know, we all know that people don't read lengthy privacy policies. So for those things that really matter to consumers, those choices should be provided at a just-in-time point. And significantly in the health area, we've said that before companies collect health information from consumers, they should seek their opt-in consent. And then finally, transparency. All companies should have privacy policies. Certainly they may not be read by consumers, but they're useful for regulators and privacy advocates and others to be able to compare practices and to kind of inform consumers. So that's kind of the main policy area that we've delved into. We've also advocated for do not track as a means of stopping online tracking, the idea that consumers should have an easy to find, easy to use choice that they can choose not to be tracked on the internet. And we're also looking at the data broker industry. We sent out subpoenas to 9 data brokers, and we are going to be issuing a report later this year that's outlining some of the practices that they engage in. And so then finally, let me just briefly touch on enforcement. So as I mentioned, we brought a lot of cases in the data security area. A recent case that we brought involving health security is against Cord Blood Registry, CBR. This is a company that advertises to expectant parents, saying that if you bank your child's cord blood with us, we can keep that cord blood and later help with certain disease treatment if your child gets sick. But what a Cord Blood Registry did not do is we allege that they didn't maintain the information in a reasonable, or they didn't secure the information reasonably. So they were collecting a lot of highly sensitive information, social security numbers, medical information, insurance information, kids information. They had all this information, and they had an incident where one of their employees was able to get some backup tapes and an unencrypted laptop, drove around San Francisco for several days, and the laptop was stolen and the backup tapes were stolen. And we allege that Cord Blood Registry did not have reasonable security and reasonable procedures to secure the information that it maintained. So I'm going to stop there, and I'm happy to answer any questions at the end, but I'm very much looking forward to the discussion as it pertains particularly to areas in which we have jurisdiction.
Thank you, Maneesha. Kim.
Hi. So when I was asked to be a part of the panel, which I was so excited to join, I think I have a different perspective being from LexisNexis Risk Solutions. The perspective that I'm starting with, at least in the discussion, is around some of the emerging trends that I'm seeing. One of the big important things for us is to try to figure out how to balance. There's 2 things that we think we're looking at: the whole area of privacy and then the protection of personal data. So our customers come to us to ask about how can they better protect information by making sure the right person gets access to the information. So they look at things around verifying the identity of a person who wants to get access to prescription history data or to get medical records. How do they have authentication solutions that people are really willing to utilize? I don't know if any of you all saw some of the articles last week about tattoos for authentication or swallowing a pill to authenticate your identity. I really don't know how people are going to be interested in doing some of those things. But the whole idea of trying to find a right fit for protecting access to information is really critical. One interesting thing is that we talked about the fact that mobile devices are the probably most desired form of contact and access nowadays. More people probably use their phone to surf online than their computer or a tablet. They might use that as well. So things that are more easily accessible. And so one of the things that we started to see was that a lot of customers of ours who were using certain types of information to register an identity, they couldn't ask for as much information because they didn't have the real estate to ask for it. Trying to put as much information on that little screen is not easy. So that's really kind of a good thing, because for many years we've talked about data minimization principles and asking for less information. So maybe when you shrink the screen size, all of a sudden you actually do have to ask for less information in general. So kind of piggybacking on the duo before lunch, Sweeney and Robertson, I think that they had amazing information that we all heard about. And we had done a similar study. We looked at 300 million identities and tried to understand what can become, what identity attributes help have you become a unique individual. So what elements can I look at and resolve to one person uniquely? So we looked at combinations like if I have just your name and your zip code, how often can I uniquely resolve to one person? And that's really important because there's been a lot of things on the e-commerce side in California and Massachusetts where they actually said the zip code is PII now, in a lot of other states where they have had this combination of first name, last name, and zip code and had a lot of concerns about that combination. So the question that we had was, is that hype? Or is that really a real concern? And when we looked across our data sets to try to determine that, we really saw that it was a 70 to 80% of the time you could uniquely resolve to one person with just first name, last name, and zip code. So we start looking at information combinations, so things like dates of birth. Actually, the Harvard site that Dr. Sweeney talked about is great. I was surfing it while she was talking. And our larger study really does support exactly the same kind of things that she was looking at as well. So we spend a lot of time trying to help our customers in being able to only ask for the information they need to ask and giving them guidance on what pieces of information are, help their business process. When it comes to healthcare, that's really critical because we really want to make sure that no one else gets access to my medical records besides me or someone that I have authorized to have access to my records. So I'm going to stop right there, but the issues around data minimization and privacy principles are really hand in hand for us.
Thanks, Kim. Adrian.
First of all, a spoiler alert. It's 7-2 in favor of the cloud. Now, if you, I don't think you can read the screen. The print is too small. Let me just mention, because not everybody here knows, there's a need to standardize and to make comprehensible these privacy policies and the policies of various data holders in a way that kind of like, ideally, it should be like a nutrition label. People should be able to expect that there are a couple of dimensions, how many calories, how much fat, is in a particular service that we're involved with, without having to dig through 15 pages or depend on the FTC lawyers to do it for us. So I won't go into any of the details. All of it is online on the PPR site, but suffice it to say that one piece of progress in this area is the PPR framework that was just passed out. And so what I just want to do as an example of how that framework might be used in any domain, not necessarily the cloud, but I'm going to use the cloud, my couple of minutes here, to go through the 15 practices as a way of introducing some, whatever, our point here relative to the cloud discussion. And so very, very briefly, where's the 7 and where's the 2? I think the cloud wins on principle number one because it's easier to find the policies when they're in the cloud than if you have to go to each data holder one by one. Number two is the same. Number three, deciding whether to participate. I think data in the house or in the institution wins there because you have more of a choice as to whether, in other words, your decision is less coercive than it is if you're dealing with Google, let's say, or Facebook or some major cloud provider. Number four is the same. I'll say number five. The cloud wins there because the convenience of, again, putting your decisions in one place and your indications is certainly greater than having to go to 7 different places around town. Number 6 is the same. Number 7, I think, is the cloud. Number 8, I also would score the cloud on the basis of clarity. Number 9, I would say, is the same. Number 10 is maybe the same. Maybe the cloud wins because of the inherent notification capability that comes along with using a cloud site. Number 11 is the same. Number 12, the house wins because at least they can give you, you know where to go to get answers, and often in the cloud you just don't have a phone. Number 3 is the same, and number 14 and 15, I would score to the cloud simply because they're more professionally run than many of the sites in healthcare in particular, and because the expectation of receiving a copy of your data when you know your data is in the cloud is almost inherent, whereas when the data is in-house somewhere, you often can't get a copy of it, whereas in the cloud, almost by definition, you can see your own email. I'll stop right here. I think I've made a little bit of a point about the framework and how it could be used in other cases, and hopefully maybe we'll come back to some of these in the conversation.
Thank you, Adrian. And John.
Good afternoon. I'm John McDaniel, and I'm actually going to take a little bit of a different perspective. I'm actually representing the provider organizations in the world, and that's where I've spent my entire career. So I look at all the issues and challenges that the policymakers are addressing, and I've got to figure out how to implement it so that we, in fact, ensure privacy through some secure mechanisms. I know our topic is the cloud. I saw the title, Patient Data. And first thing is I'm going to take exception to that title. I really think it deals with person data now. We're starting as provider organizations not to manage this specific point of care, but an entire lifetime of care, which if you think about that embodies a lot more than just taking the vital signs from this last encounter. It involves understanding what you're doing from a lifestyle perspective, from a dietary perspective, from a health maintenance perspective. So it really encompasses a lot more data than we've ever looked at in the past in terms of being able to manage wellness, to do prevention detection, to manage different states, and to make sure that when a patient does present, they present at the right time. The reason I mention all those things is I firmly believe those applications will be cloud-based. If you look at where the cloud is going, and I couldn't agree with Adrian more, the market projects, and IDC specifically says it's going to be a $200 billion market within the next 7 years. That's exponential, and that's in healthcare. That's exponential growth. So that means a lot more information is going somewhere in the cloud than has ever been in the case before. So obviously the impact of securing that information is very significant. Why, and what are the applications that we're looking at going into the cloud? And one we really haven't talked about, but I think there's a topic this afternoon that's kind of my passion in life now, and that's the whole big data or clinical analytics. So I see analytics as a service, which means the movement of a lot of patient information into a cloud so that organizations with the appropriate access has the right to analyze that and do the wellness prevention kind of things I talked about earlier, even using genomic markers to understand what I'm predisposed to so that they can manage my illness from that perspective. The second one's application as a service. No longer as an industry, can we afford to spend $100 to $200 million for EHRs? We just don't have the funding to do that anymore. So I'm seeing cloud initiatives or cloud offerings being developed around some of the major EHR providers, Cerner specifically, Meditech, you're starting to see that. So I think you're going to see that evolution continue. That's a huge demand and huge market for cloud services. The last one, and I think one that has a huge implication on privacy, and more specifically around encryption, is in the area of infrastructure as a service. Our data over the next 10 years is going to grow at a 46.6% compound annual growth rate, which means it's going to be doubling pretty quickly every few years. Is that significant? I think a lot of that storage will be cloud-based. What are the reasons for that? You've kind of heard a lot of those things discussed earlier. Obviously, the establishment of accountable care organizations. The mandate that I'm now going to take either on part of the risk or all of the risk of managing the care of that patient and the dollars associated with that care implies I have to have access to all the medical information about that individual in order to deliver the appropriate care at the appropriate site. In fact, I go as far to argue that if you look at the universe of provider organizations today, at least from a hospital-based perspective, I argue, and I think pundits agree with me on this, that about 40% of those organizations named today as hospital-based organizations will cease to exist. You'll see them either merge or form some other organization, and you're starting to see it happen now. Again, the issue is I've got to move that data from those organizations, which will probably still operate under a different name, into something larger. The second area, we talked a lot about that, is the health information exchanges. I think those are also going to grow significantly, and I see a majority of those being cloud-based. The third one is around, and this is something that I think is really key, and it's going to drive a major emphasis on privacy, and that's patient engagement. And what I mean when I say patient engagement is I think to do a better job of caring for the patients going forward, and I'd like to hear Adrian's perspective on this, is I, as a patient, has to be engaged in my care. I have to take ownership of that. And the only way I can do that is through communication tools and uploading certain information about my vitals currently so that there can be algorithms built to predict what might be my next illness state. So I think that's going to increase demand. And part of that is, are you familiar with the BYOD concept, bring your own device? I think that's going to be exponential growth. Another reason for this information to be put in the cloud, secured in a manner, and not even downloaded, just maybe accessed from those types of devices. I think the biggest thing is, if you really look at it, is the dollar. I'm going to give you a new term today. I talked about exponential data growth, and it may not be a new term for those of you that are in technology, but we're expecting a yottabyte of data in healthcare within the next 5 years, and a yottabyte is 10 to the 24th power. It's a huge amount of data about patients that will be maintained in the cloud. So I think that kind of concludes my kind of conversation, but I love to interact with people on questions around the provider side.
Thank you. We had a terrific discussion among the panelists when we were getting ready, so I don't want to cut off time for all of your questions, but I want to give everyone a chance to respond to each other because, as I mentioned at the beginning very briefly, each of the panelists has a unique and very rich experience in this whole area. So I'll just go down the line. I'll start with Maneesha, and then Kim, Adrian, and then back to John, and then open it up for any questions you have. If you don't have questions, I have some myself, but I'll start with Maneesha.
Yeah, so I think this has been very interesting hearing what the panelists have had to say, and I just wanted to make 2 points in response. I guess the first is just kind of a clarification. I feel like we should kind of clarify our terms, and there are many different kinds of cloud models. And so one model is you go to a hospital, and the hospital puts your data in a cloud. I think there's a different kind of legal framework that applies to that. Another model is I kind of have my own, device, like my fitness device or whatever, my small app, and the app stores my data, contracts with Google or somebody else to store my data in the cloud. that's another model which has a different legal framework. And I think maybe a third model is, I just store my data directly, with Google or something like that. So I think each of those models has a different legal framework, has different implications. And so I think we should just kind of make sure that we're not kind of talking at cross purposes. The second point I wanted to make is the topic of analytics was brought up and big data. And I think that's one of the most interesting areas, the intersection of kind of use of analytics to have better medical outcomes, versus the privacy of the people who are actually, whose data is in the cloud. HIPAA, as I think people know, has a very kind of has a very, well, I won't say clear, but has a de-identification standard. So if data is de-identified, the HIPAA protections don't apply. Under the FTC's privacy report, we have a slightly different approach to de-identification. We have said that it's kind of a reasonableness test. So there are 3 criteria in order for data to be de-identified and not necessarily subject to privacy protections. One is that you have to take reasonable steps to de-identify. 2 is that you have to make a public statement that you won't attempt to try to re-identify. And 3rd is to have contractual downstream protection so that you don't share data with anybody who tries to re-identify. Once you meet those criteria, then you don't need consumer choice. At least that's how we've spelled it out in our privacy report. And I would just be interested in having some discussion on, what are the kind of relative benefits and trade-offs of each approach.
Kim.
So for me, around the whole discussion of patient engagement is huge. When I was in graduate school, I focused heavily on information asymmetry and how in healthcare especially, the patient often feels that they're very unbalanced. Things have changed tremendously since I was in graduate school many years ago. Before there were even medical ads on television, and that was a big deal to get those on TV. But the fact was, and before there was WebMD and things like that, so you didn't have access to even know how to self-diagnose yourself and get yourself scared about some illness you don't even have. But this whole thing around getting access to your medical records still is very foreign to a lot of people. Most people do not, either they've made a decision to not want to figure out how to get engaged in keeping their medical records, because that sounds like a nightmare to them, or they don't know how to access their medical records, and they don't even think it's their data. So these discussions about personal clouds and controlling your data and being more involved, I think for the general public, most people don't get that. They don't understand where to start and how to be involved. But as soon as they do, yesterday I was at the FTC Mobile Summit where they were talking about mobile security, and the whole concept of some devices are more secure than others, or operating systems have different impacts, or that you could run into malware, or all these kind of things. When you think about that whole concept of bringing your own device to getting access to your medical records and possibly screwing things up completely, that must terrify, it scares me. So I just think that this is such a complex situation when you start with the patient engagement piece. It's going to be interesting just to watch how it evolves.
Thanks, Kim. Adrian.
Well, I don't mean to sound combative, but I'm going to be a little bit combative here because, frankly, I want the FTC to protect my right to anonymity in the sense that Mark Rottenberg talked about just a few minutes ago. I want to ask Maneesha if the FTC gives me the right to opt out of the re-identification by LexisNexis.
We don't do that.
Could you spin out the scenario? So opt out of re-identification. So
LexisNexis is in the authentication business. Mm-hmm. And the responsibility for privacy-related issues, or FTC-related, whether they're HIPAA or FTC, is split between LexisNexis, that manages some database that is used to authenticate me, or de-anonymize me if you prefer, and the customer of LexisNexis who collects the data that is sent to LexisNexis under some privacy practice that may or may not meet the framework of whatever. And so, simply put, this is the pure cloud in a sense. And from whatever perspective you want to take this, either from the point of view of whose privacy practice applies. Does LexisNexis have to have a privacy practice? Are they subject to the framework? Are they not at all subject to the framework because they're not data holders, or because it flows through in the HIPAA omnibus HIPAA rule, which obviously isn't the FTC rule? I'm confused.
Okay, so I can think about 10 ways to answer that question, but let me just take a stab at it. So, LexisNexis would be covered by the FTC Privacy Framework. And the Privacy Framework is, best practices. In terms of laws that we enforce that apply, there is a law that LexisNexis is subject to called the Fair Credit Reporting Act, which is basically a use-based law. So if LexisNexis uses information for, to sell to, for employment purposes or credit purposes or insurance purposes, then there are certain protections that apply under the Fair Credit Reporting Act. There's not an ability to opt out, but there's ability to get notice, to correct erroneous information. So there's kind of the legal framework that applies in that scenario. I think in terms of opting out, of public information, let's say it's used for marketing purposes. Let's say somebody uses LexisNexis's information for marketing purposes. There's not a legal right to opt out. And I think one of the things that we're trying to do is trying to get a better handle on what's happening in this industry where people are using public record data for marketing purposes, and that's one of the reasons why we issued these subpoenas to the data brokers to try to figure that out. But it's a complicated question, a lot of laws that apply, and I think we're trying to look at it from multiple different angles.
Thanks. I want to go to John, and then I want to see if there are questions from the audience.
Okay, well, I've got lots of questions, so I'll try to limit the number. But back to, and I appreciate you distinguishing between the various, there's several thousand ways to describe different words for healthcare. But one of the questions I have, and I think I totally agree with the de-identification of patient information for marketing purposes and for research purposes, but I vehemently disagree on the care provider side. If I'm using that data to care for a patient and I've aggregated it and I am a consented physician to use that, I can't de-identify that information. So how's the FTC addressing that, or are they?
So certainly, just in your scenario, would the provider have gotten the consumer's consent?
It would have been implied consent, because I don't know necessarily. Let's say I schedule an intervention or I schedule an appointment. I've been triaged from one doctor into another place. You don't know who that doctor is going to be yet yourself, but that doctor needs to have advanced knowledge of who you are before they spend time treating you. So it's that. So there's an implied consent associated with it.
Yeah. So I mean, I think this is the reason why we have consciously kind of excluded the kind of. This is an area we don't have expertise on. So I don't think I'm qualified to answer that question. I think that's where we say, okay, now you go to HIPAA, HHS, you take that. So I think our framework has been more on the. The other areas, the kind of health information not collected by healthcare providers and others.
I agree, and I think that's been part of the challenge of the provider. We don't know where to go. Yeah. Often to ask the question to get a ruling. And I think we need better, clearly delineated, who do you go to in this case? And I think that's a great answer.
So before I ask a couple of questions, I want to open it up because I know we only have about 20 minutes left. Are there people who have questions right now of the panel? And if so, can you come to a microphone? And what I'll do is the right, left, not politically, but just visually. Right?
Are you right-handed?
I am right-handed, so I lead with my strength. Thank you.
I'm a technological dinosaur.
Can you speak a little louder?
I don't know.
Thank you.
I don't really understand about how the cloud works. Could you please explain for people like me how the cloud is different than computer systems, and in terms of going after, hacking patients, saying this doctor could see my records versus another doctor? How much privacy concern? How's privacy going to be protected in terms of everything, encryption, hacking? How is that the same or different as other systems?
Right. Thanks. It's a great question. So I don't know who wants to go first. Adrian had the lean in.
I think both of us need to answer this, but very simply put, the cloud is, when data is managed or stored in-house, there's a very clear responsibility of one party. There's no phone companies involved. There's, who, like I said, it's easier to find out if you have a complaint or to correct an error because you know whose door to knock on. The cloud often blurs that distinction, sometimes intentionally, very often intentionally, but sometimes just because of the way it works. And
yeah, I could actually make this a really tough conversation. 'Cause I could start to talk about private cloud and public cloud.
And combination.
And combination hybrids. I think Adrian said it right. I think basically what happens is an institution decides to move a large amount, all or part of their information into storage or a provider outside or a hosting service outside their organization. That's what we refer to as cloud. If you think of Amazon or Google or I can't think of it, even Facebook, that's a cloud solution. They're hosting and maintaining your application on their site.
There was a great question a number of years ago about whether, this is not the topic for today, but is cloud really new, or is it just the old off-site computing that's now gotten a cuter name, a better name, or a more interesting name? So I'm going to go over to this gentleman.
Okay. John Bogan from IBM. Can everybody hear me? A comment and a question?
Sure, please.
Patient data in the cloud. Well, actually, I agree with John McDaniel, which is really person-level data, because we think of things going to provider, they're going to have your lab data, they're going to have your encounter data, various bits of medical data. But there's a whole issue of genomics and proteomics data. So, I guess I see in the future, if we look at, the provider having the cloud, it's really moving to where the person, kind of a health vault model, where they have all this data spread out all over the place. So my question is, where do you see the impact of genomic and proteomic data in terms of increasing the incredible amount of data,
Right.
and where that may, kind of disenfranchise the provider model?
It's interesting. It also goes to one of the underlying questions, again, not for today, as to who really owns the data when it gets put into the cloud. So I'll look to the panel to see who would like to take that question.
I can take a shot. I think today, if you look at the actual storage footprint required by genomics, it's minimal. However, as we learn more how to use that data and we get more sophisticated in developing the marker scenarios, I think that will grow significantly. There's a number of projects around the country. Duke Medical Center comes to mind now that's doing some extensive work in that area, and they've had great results. I think at the end of the day, the conclusion is, if it's my genomic data, I still own it, though.
But it's still an interesting question.
It is still an interesting question, and one I'm sure will be challenged in courts at some point in time. Great questions, by the way.
Just before we go to before I go to this gentleman, I wanted to mention, and this is an old Fed habit dies hard. Maneesha is here in her personal capacity. The views she's expressing are her own and not of the FTC. Thank you, gentlemen.
Hi, my name's Phil Corin. I recently joined a company that's moving towards the cloud in clinical research space, and one of my general questions is, there's a lot of pushback sometimes from our clients, but just generally, that there's certain types of information that would never be appropriate for the cloud type of model, which, because of its sensitivity or concerns around security, would just never be appropriate. And I don't personally agree with that, but I just wanted to get a pulse on that from the panel, if anyone has a view. And then I have one more quick question.
So I'll start. I can just go straight down if that'd be okay, Maneesha.
So I guess I feel like I don't want us to vilify the cloud. I feel like, there's a lot of times where there's economies of scale, and having information in the cloud can actually make it more secure. Who would you trust when using an app? Two guys in a garage storing your personal information, on their server, or, having them contract with Google or somebody else that, has these economies of scale, knows how to do security. So I guess I don't agree with that statement.
Yeah, I think for me, the only thing that, from a LexisNexis perspective, is whether your information is shared information or if it's just your information. So there are many times when you may choose to have someone else host your information, have it in the cloud just for you. And there are times when you may want to have information shared that can go across light companies or whatever. So I think those are important decisions to make. When is it only for you to see, and when it should be shared with someone else?
I would second that. I would say that the information is valuable to me only to the extent that it can be used in the ways that I want to use it, number one. Number two, I want to recall back to something that Doc said earlier this morning, that a cloud can be a personal cloud. And all of the technology and all of the goodness that you can get from connectivity and scalability and things like that can be entirely under your personal control. And so, you know, there is nothing, so there's nothing I can think of that you couldn't hang the cloud moniker on and find a reason to do that.
Actually, I agree with what everybody said, but I would add one thing to it. I think we also have the ability to stratify how sensitive that information is. In fact, I think we can take what we've done in most provider organizations where we've done stratification around security and sensitivity of data and extrapolate that to the cloud.
Thank you. I'm glad to hear that. And I'll let the next person ask.
I'm going to go over here and then I'll go over there. Sorry.
Hi, this is Andy Orm. I'm an editor at O'Reilly. I was hoping that someone would refer to LaTanya's data map that she put up earlier. And that sure looks to me like a cloud. And might it be better to say, let's put data in one place, whether it's the patient's control, the doctor's control, and say, you cannot send it to other people. All you can do is give them access with permission, and that access can be revoked.
Wow, I wasn't going to touch that. I agree with you that it's the cloud, but when I was listening to her, and I think she made some excellent points, I saw that as not necessarily accessing my specific information about my specific health conditions. I mean, that was an aggregation of a lot of data from a lot of sources. So there were multiple, I guess I call it in this case, cloud sources where that data was assembled. From the standpoint of what I'm talking about stratification of the information about me stored in a remote institution that is secured and can't be accessed for those kinds of purposes. That's it.
And I don't see any particular reason to insist that data has to be in my personal possession or in one physical location, though I think we also want to make sure, however, that we don't introduce technologies or policies that prevent that, that ultimate personal autonomy that we've enjoyed before cyberspace or before this technology from continuing going forward. So I would I would restate, I think, not invert, restate your question as saying, I think we should make sure that whether it's with respect to identity or health records or most anything else that's moving into this cloud or digital domain, one test which we should have is, could this be plugged into your router in your house or into your parents' house if they have a better internet connection, if that's where you feel like you want to keep your data.
And I'll just add one comment. As I was sitting there thinking about it from a privacy perspective, and I was surprised more people didn't get angry when they were called, because my first reaction would be, and I'll say this in a nicer way, is how did you get that information, and did I actually give you permission? So I think one of the, and I won't use a bad pun about the cloud hanging over the cloud, is that I think that there are a number of consumer misconceptions about what the cloud is. So anytime that people talk about the cloud, I kind of default to a question of, do the consumers understand it, and how much control do they actually have, to the gentleman's question about, is there anything that shouldn't go in the cloud? If it's my employer who's putting my information in the cloud, or me personally, do I get a chance to say yes, no, or maybe? So that's just my thought based on your question and on the conversation this morning.
Can I just react to that also? I mean, I think that, we've talked about the fact that, there could be economies of scale and there are pros and cons and that sort of thing. But I think, we're a regulatory and enforcement agency, and ultimately we are going to hold the consumer-facing company liable if something goes wrong when you put data in the cloud. So you can't just say, oh, I put it in the cloud, no, not my problem, not my responsibility. You're the organization that's going to be on the hook if there's something that goes wrong.
And I want to add also that I don't like the term the cloud. To me, it makes it sound like this is one big thing up in the sky. And I would much rather somebody say, who is your data being hosted by? Where is your data being accessed? Who is hosting it? And there are times when, going back to this outsourcing concept, where it makes more sense to have someone else host the data for you. There are other times when maybe you do a better job of hosting your own data and limiting who has access to it for other purposes. But the word cloud, besides feeling a little sexy or whatever, I think it's confusing.
Exactly.
And so I would much rather say who is hosting your data. And so there are times, for example, biometric data. Maybe a company may not want to host their own biometric data if they're using it because they don't understand all the regulatory rules around it and how it varies by state and how it varies by country, and they don't want to have to manage all of the rules around it. And so they say, let me find someone else who can host this information for me and handle it properly and have me comply with all of the regulatory rules. Hosting is a much better word to me. I like old school.
And I agree, because again, it goes back to the, is this really just a new name for what had been done? I know you're shaking your head no, but remember a couple of years ago when cloud was, and I will use a bad pun, burst onto the scene, there was a lot of that discussion. You've been waiting patiently. I'm going to turn to you, and then I'll go back to the panel. Let me ask her a question.
So I'm a physician, and I am contemplating all this, and I think of that garbage in, garbage out phenomenon. And I also think about whatever usefulness this may have. I mean, if meaningful use is important for electronic medical records, boy, oh boy, when I start thinking of bring your own device and the concepts of whatever may come about as people are doing tests with devices for which it's not clear they're good or not, or they're collected in the appropriate way, that you're potentially getting false positives and false negatives, and then essentially creating this huge data dump for which neither the patient nor a physician might be able to make any sense out of. I'm wondering how this is all kind of being conceived from just that standpoint of what is the utility of something that's not only potentially going to be posing security issues, but also putting a patient's health at risk, given even with, say, a simple test like the PSA. We as physicians have seen that tests fall out of favor. We have seen tests, the thresholds at which abnormal results, and therefore then the treatment through drugs is lowered. And all that raises red flags, because if it's teach the test in education, it's treat to the test in healthcare. And Lord knows that's not helping healthcare costs nor outcomes. So I just would like to know your comments regarding that.
Do you want to go?
I was going to ask Adrian as a physician
I was
if
about
you
to
wanted.
say we're all defaulting to Adrian. Go ahead.
I actually don't understand the question. I am trained as a physician, but as an engineer, which is the way I approach these policy issues, privacy or otherwise, or a technologist, there is nothing about one kind of data other than identity data, things that I cannot separate myself from, like a genome or a photograph or a highly detailed MRI, or anything else, or a tattoo, in effect. So I really only see two kinds of data, wherever it is, in a house, in a cloud, anywhere else. Those that I cannot separate myself from voluntarily, like the ones I said, and those that are like a result of a test or an interaction with a physician, which to me are all the same. And in a sense, what I'm saying is I don't see it having anything to do with the cloud. If I understood, I may have misunderstood your question, but that's the way it came across to me.
I understand your question, I think. What you're saying is with all this data in the cloud, and you as a physician are going to use that information to make clinical decisions about John McDaniel's care. If that data is inaccurate or garbage in, as you said, you may not make the right decision. Or you're going to duplicate the testing process to ensure. That's really what you're saying. And I think that's a great question. I don't have the answer. However, I can tell you organizations that have gone through pilot projects of this, one's in Southern Illinois, Carl Health System, Intermountain, UPMC. There's a number that have demonstrated a huge return on investment from using technology to help manage the patient care. They're still not managing the patient care, though. That's still the physician that's managing the patient care. So I think the challenge is to make sure we have the right kind of data going in. And one of the key issues in healthcare organizations today is establishing data governance committees.
Right.
To make sure that, one, we've identified the source of the data and the truth of the data before it is ever loaded into any analytics tool or EHR. So there's a lot of validation that's taking place in there, but is it 100% foolproof? Absolutely not. Are we getting better? Yes.
I think we have time for one more question. I'm looking up at the clock, and I'm looking at Kat. Do we have time?
Yeah, 5 minutes.
Okay.
Okay, I missed the very beginning of the talk, so it could be this has already been covered. But I'd like the panel to address siloization, the isolation of all this data in so many different places. John spoke about the Yolabyte that's accumulating out there, but offline between panels earlier, we was talking with Adrian and some others about how a single visit to the hospital may generate 4,000 pages of documentation about something that could be reduced to far less if it was open to some kind of scrutiny or open source processes or other things like that. So it seems to me that the way that the system is constructed right now is kind of like it was in the 70s before we even had the PC or the internet. There are many, many different proprietary systems that don't open up and are not interested in opening up, with no incentive to open up. And as long as that condition persists, we'll get bigger and bigger clouds that are more and more isolated. So.
You mean more multiple clouds that are?
Yeah, well, yeah. I mean,
Yeah.
just but I think you guys know what I'm talking about. So.
That's a great question, and obviously you nailed it. There really hasn't been an incentive. In fact, it's been a disincentive on healthcare solution providers to standardize on their products. So in fact, they've created different storage sets of information, whether it's a radiology system, some other PACS system somewhere else, a lab system, an EHR, whatever it be. They could all be from different vendors, and standardization is obviously a real challenge. I actually see the cloud as being a solution there, because there's work that I'm talking to a number of clouds now that we work with as partners that are developing tools to take that data from those various disparate sources and aggregate it in a standardized, normalized database so that it can be used for clinical care or analytics reporting.
I think it boils down to two paths. One of them is the market will solve this problem, and the other one is it has to be made into a civil rights issue, that you have the right to access and deletion of your data from a service provider if you don't like the fact that they've made it into a silo. I frankly don't know, because it's basically a technical issue, which one will solve the problem first. It would certainly be nice to be able to interpret civil rights relative to not federal or government issues, but a civil right relative to cloud providers and healthcare providers, whether they're HIPAA-covered entities or not. I don't hold too much hope for that happening, unfortunately. So I think it may need to be a market-based solution to solve it.
When I hear data silos, I think of issues around access and issues around sharing where it makes sense. So there are times when data has more power when it comes together. Taking it out of healthcare for a second and thinking about sex offender information. When I only am able to look at sex offender data in one state, and I don't realize that somebody was a sex offender in a different state because I only have a narrow view, that's bad, right? So then it makes more sense for me to be able to see it broader. There are times when it makes sense for data to be siloed, and there's times, or limited in how it interacts with other data. And there are times when you get much more value when you have that data available in a broader set. So I just think it really varies by types of data, and within healthcare, there are so many types of data that maybe all of them don't make sense to be together.
Right. Psychiatric care might not want to be coupled with something else. We heard people mentioning that this morning. Maneesha, any?
Yeah, I mean, again, I think you nailed it exactly. I mean, I think data silos, from a pure privacy perspective, I am uncomfortable when, companies out there have a full profile into my life, what I buy, what I eat, who my friends are, and that makes me uncomfortable. But I understand that there are positive uses of that information as well. So I think it's just very complicated.
It depends.
It depends. Right?
It depends. Well, I see Debra just came in, and I see Kat standing. So I want to thank you all for being such a terrific audience, great questions, and I want to thank this wonderful panel.